I'm Ashley Posey. I'm a pelvic floor physical therapist at Advanced Physical Therapy.
And my name is Brier, another physical therapist at Advanced Physical Therapy.
And today we're going to be talking about kind of where we can come in and help after a prostatectomy. So we'll Sorry, I paused the recording. Okay, so now we're jumping right in. So kind of what we're going to talk about is just kind of general anatomy, the physiology of arousal and erection, overview of the prostatectomy procedure and resulting symptoms, and then again, where we come in and how we can help after the fact. So symptoms following a prostatectomy. I'm going to trip over that word a lot. Just bear with me. You can have urinary or fecal incontinence. That's where you lose urine or stool beyond your control. Urinary urgency frequency. That's feeling like you have to go to the bathroom several times per day with a strong urge, like I've got to get there right now. Nocturia is losing urine at night. Impotence, difficulty maintaining and achieving an erection, constipation, pelvic pain, pain with sitting. So there's a pretty long list there following this procedure that can become an issue. So this slide is just kind of a cross section of the pelvis, of the male pelvis, showing, like, if you want to point to it, or okay. So Brier's going to kind of point to it as I go. It's showing you like where the bladder is and where the prostate is in relationship to the bladder, urethra, and just some of the general pelvic floor muscles. So you can see there's a lot of muscles through that pelvis that a lot of times people don't even know it exists. Several important functions. I think that's our next slide. Oh, no. More anatomy. So this is just kind of just a black and white, a little clearer picture. And this is a cross section. So like if you cut the pelvis in half, open it up like a book, this is what you would see. Again, you've got the bladder, the prostate that sits right below that. The urethra passes through that, down through the shaft of the penis. And then the rectum that forms the anus is sitting behind those structures. Bony borders kind of front to back. You've got your pubic bone or pelvic bone there in the front, and then your sacrum comes down to form your coccyx or your tailbone there at the very back. And then everything between that, kind of like that little hammock looking thing, that's your pelvic floor. All right, so functions of the pelvic floor. Why is the pelvic floor important? What does it do? There's 3 S's. I tend to say 4, so I'll say all of them. It's supportive, so it helps keep you up and in throughout the day. It's sphincteric, so it helps you go or not go to the bathroom. It's important for sexual appreciation, as well as abdominal stabilization, if you think about the abdomen being like a pressure system or like a canister. And this is just another picture of anatomy and how it relates to the sexual function. So you can see that there's a muscle right there at the base of the penis, and then there's several muscles that kind of attach right around that. So if there's dysfunction in any of those muscles, it would stand to reason that you would have some dysfunction sexually. All right. So there is a lot that goes into an erection. Cardiovascular health, hormones help control it, emotional, or your connection to your partner and yourself, how you're feeling about that, respiratory, and then neurological control from the central nervous system as well. And then this is just a quote kind of encompassing that from a male that had erectile dysfunction following a prostatectomy. Again, tripping over that word, just with all of the things that could kind of go into it. So we're going to just move on to some of the more of the meat of the presentation. So this is just the anatomy of an erection. So there's 3 chambers in the penis. You've got the synoid. I don't even know what I'm saying, chambers that kind of help with control blood flow. And then you've got the urethra that kind of passes through, obviously controlling like the urine and things like that. The smooth muscle, which is your pelvic floor muscles, helps regulate that blood flow. And so this is kind of where pelvic floor dysfunction can kind of mess up our sexual function there. And it also helps control during the rigid erection phase as well as ejaculation. So there's 5 phases of an erection. You've got the initial filling where the penis fills with blood. or the impulses from the brain and nervous system cause the muscles to relax. Sorry, I lost my place there. And then you got the partial erection where the blood starts to enter the penis. You've got the full erection where the increased blood volume prevents the draining, compressing the penile vein. And this is where, like, if you've heard of like a penile ring, can help support and kind of help facilitate the erection or maintain. Then you've got the rigid erection. The penile vein is fully compressed. And this is where the pelvic floor muscles kind of help come in to kind of help prevent some of that blood flow out of the penis. And then at the end, you've got your resolution or the return to flaccid state. So defining erectile dysfunction, it's defined as the inability to achieve or maintain an erection sufficient for satisfactory sexual performance. So you can see, even with that definition, it's not a super clear-cut thing. So the prevalence is really challenging to kind of nail down. And you can see just the range there, the reported prevalence is 13 to 71%. And that may not even be a true accurate report rate. It can increase with age due to changes in blood flow to the penis as well. So again, that cardiovascular health is important. And then ED management in a timely fashion is very important for the well-being of the sufferer and their partner, just to help kind of get on top of that. And then these are just some statistics. Obviously, it's a significant quality of life problem. And then you've got your erectile function recovery rates are highly variable. Again, a wide range in that statistics, 25 to 78%, and an 18-month follow-up. And then that's a different type of procedure with a robot-assisted laparoscopic prostatectomy. I don't know why I didn't trip over that word when I've been tripping over everything else today. And then again, age can impact your recovery. With patients less than 60 years old would have a higher percentage of 77, compared with over 60 would have like a 61%. And then if we define that as a return to baseline erection without medications for ED, the numbers kind of change a little bit. So you've got 22% at 24 months post-op, 4% of men greater than 60 years of age return to function without medication after the prostatectomy, and then less than 15% of men report sexual satisfaction after prostate cancer treatment. So lots of numbers just kind of thrown out there. What does it mean? Being educated on your options for support from the care team. That's a huge deal. That's kind of why we like to get out and do these things with our education and things like that, so that you know pelvic floor is an option, or pelvic floor therapy, is an option. And then educating about some of the other things as well. Okay. Is that you?
Yeah. All right, so let's talk about the sexual function of the pelvic floor muscles specifically, because that's going to be their main role during erectile dysfunction or function. So there's a couple different types of arousal. There's an initiative arousal or responsive arousal. So that we'll get into that psychological aspect a little bit later, but the pelvic floor muscles respond to arousal by contracting and relaxing appropriately. So that can be contracting in order to compress that vein to maintain an erection. If you don't have the endurance or strength to compress and maintain that venous blood flow into the penis, then you're not going to be able to maintain the erection. Or it could be a problem with the coordination where they can't get that rhythmic contraction for orgasm. So can strengthening the pelvic floor muscles improve impotence? Maybe. So the research is kind of mixed. Again, we don't have a whole lot of research, and it's really widely underreported. So that's why that maybe is highlighted in red there, just because of the lack of research in journals. So what we do know from the research that's out there is that early pelvic floor muscle training reduces the quality of life impact post-prostatectomy. And what that means is that early is the key word there. So pelvic floor muscle training, we like to see people like for 1 or 2 visits actually before your prostatectomy. And that depends on the surgeon's recommendations as well. But we do see a faster return to continence and erectile function if we can see people 1 to 2 visits before the prostatectomy. Some of the studies out there have a 12-week protocol. Other protocols may look more like starting 2 weeks after prostatectomy or 4 weeks after prostatectomy, again, just depending on the surgeon's specific protocol for their surgery that they did, because not all prostatectomies are equal. They all have a different procedure, so your protocol might look a little bit different from someone else. So don't worry if your surgeon kind of recommends something different from someone else's surgeon. So exercises for the pelvic floor are really important to be monitored by a trained pelvic floor physical therapist. So we're specialized in being able to detect whether you're functioning with those muscles appropriately. There's 2 groups of pelvic floor muscles. So I think we kind of covered this. Let me stick this model back together. Ashley covered this in the beginning with her anatomy lesson for you guys. But there's a group of muscles back here around the anus, and then there's a group of muscles more up here around the base of the penis. And they function separately sometimes, especially after prostatectomy. So you could be using one of the groups of muscles correctly, but not both of them. And so that's what we're here for, is to teach you, yes, you are doing it appropriately. No, try it this way. And make sure that you're using all of those muscles involved, because that will be necessary for you to be able to make the gains that you need to. And then we can also assess for hypertonicity, which just means that there's like a spasm or overactivity in those muscles, which can happen after surgery as well. And we can kind of help you to decrease that spasm, decrease that tone, and get those muscles happier and healthier. So basically the gist of all of this is that pelvic floor muscle training is simple, safe, it's non-invasive, and therefore it should be a preferred approach in the management of erectile dysfunction. So radical prostatectomy, like I mentioned before, there's a couple different types of prostatectomy, but with the radical one, that's where we see the most erectile dysfunction. And you've had that version of one. So a couple of things that we see contributing to erectile dysfunction is damage to or removal of the erectile nerves, because they need to get them out for the appropriate procedure. We see a lot of inflammation and scarring in the pelvis. Sometimes arterial damage can occur just from the technique that they use. And then that can cause all of the things over on the right there: loss of ejaculation, pain during orgasm, pain following orgasm. Penile shortening is a big one that they don't tell you about usually beforehand, that happens as well, and that can affect the venous flow, and then also infertility factor. And again, not all of these things happen to everyone, but some of these things can occur together or in isolation of each other. So these are just some really common ones that we see. And then especially with radiation. So if you have radiation, you're more likely to get more of these or have them last a little bit longer. And we can help you with managing that as well. There's also the key player of hormone imbalances. If you've had prostate cancer and you're having hormonal intervention as well, then that can play a role in building back that muscle mass or not building back that muscle mass. So beyond pelvic floor physical therapy, there's some other holistic things that we can help you with or refer you to others to get help with, including dietary aspect of it. The dietary aspect is huge because it's what you're fueling your body with. So yeah, we're helping you with your muscle function and your nerve function and your movement of your pelvis and blood flow, but what fuels all of that to happen is what you're putting into your body. So that's a really important player. And you'll hear us talk about that a lot when you come to physical therapy, and we may even have you talk with the dietitian to get that on track and just give you the guidance that you need and deserve for that aspect of it, because your muscles can't work if you're not fueling them with the right things. And then exercise. So when we talk about exercise, that can mean a lot of different things. It can look a lot of different ways for everyone. But generally what we're meaning is something that's going to get your heart rate up, moderate to vigorous. So you should not be able to hold a phone conversation while you're doing this type of exercise. And we were wanting you to do 30 minutes 3 to 5 times a week. So that's going to be for that cardiovascular system effects. Again, the venous part of erectile function is one of the largest aspects of it. And so taking care of your cardiovascular system is going to be really important. And that's something that will, guide you in doing, but have you doing at home most of the time. So there's other benefits, not only the cardiovascular to the 30 minutes of vigorous exercise for 8 weeks. There's also the decrease in inflammation, and then also the stress effects. So we touched on the psychosocial aspect of it, but the psychological aspect of it and stress management is huge for this. And so here we go, psychosexual counseling. So we can refer you to a certified sex psychologist to help you and your partner increase the arousal and increase the psychosomatic part of it. Depression is a big one with erectile dysfunction, just because of the shame complex of it. And then it's frustrating, it can be incredibly frustrating on your relationship as well with your partner, because it's something that you are not in control of, and it's impacting that intimacy that you want to share with your partner. So we can help you get in touch with the right people. Someone here at UAMS in Little Rock is Dr. Chelsea Wakefield, who we refer a lot of people to. And she's wonderful. She has some books out there as well. So if you're not ready to really take that step to go speak with someone, she does have books available online. And if you message me in the chat, I can get you the link to that. There's a couple other devices that we can have you work on at home too, if you're kind of plateauing in therapy, or if we get you to a point where you're independent with most of your exercises at home, or if this is a tool that you just use before intercourse. There's vacuum devices or penis pumps, as you've probably heard. And there's also, what are those rings called? Constricting rings. That we can teach you how to use safely, because there can be adverse reactions to these if you don't know how to use them, or try to train yourself on them, or if you just YouTube it. There's lots of YouTube videos out there. We all know YouTube is dangerous. You wouldn't take well, maybe some people do work on their car from YouTube videos, but but if you want your car working right, then you're going to take it to a mechanic to get it fixed, right? Yeah. So highly recommend getting trained in using these devices before you use them at home, and we can help you with that. There's also oral medications, injections, suppositories, all kinds of things like that. You can implant penile pumps as well, saline pumps. So there's tons of other options out there if physical therapy isn't working for you. So it's not the last ditch effort. A lot of people will come into PT and they've tried a lot of things before, and it feels like this is my last resort. But this is just another part of the pathway that we're seeing if it works or not. Just like when you try any other medication, sometimes that medication works for you, sometimes it doesn't. You have to try another one. So PT is kind of the same way. If we can help you, then great. If not, then there's other options out there as well, and we're not the end of the road for sure. So focusing on the pelvic floor muscles and the deep core. So Ashley mentioned the deep core canister that helps the pelvic floor muscles. The pelvic floor muscles don't work in isolation of all the other muscles. So they work as a system with the abdominal muscles, the lower back muscles, and the respiratory diaphragm. So we're going to help you get all 4 of those deep core muscles working and coordinating appropriately. We're going to assess the strength and coordination and endurance of all of those during functional tasks. So we're going to be watching you move and do things that you do throughout your life. And that's part of getting to know you during the first visit, getting to know what your daily routine looks like. That way we know how your body's moving, so we know how to assess your body as well. And then we're also going to be discussing behavioral modifications like diet, like getting that adequate amount of vigorous exercise in, and see if any of those lifestyle factors are contributing to your symptoms. So what does the first visit look like? This is usually everyone's question, is like, what are you going to do when I come into the office? We're going to do a lot of talking the first day. So we're going to sit down one-on-one in a room. We usually book at Advanced Physical Therapy. We book 60 minutes with you for your first visit. That's from front to back. So you're telling us all of your medical history before your prostatectomy, because all of that matters too. The way we treat is you're a whole person. You're not a prostate or lack of prostate. All of the stuff in your body matters into your function. So we've kind of touched on that a little bit throughout, including cardiovascular, back surgeries, Some of the things we might ask about is other abdominal surgeries. Have you ever had a hernia? Do you have kids? Have you ever had pelvic pain or pleurisy? Those kind of things all play into this. So we want a thorough history, and some things you might not think of when you walk into the door, and we might ask you some questions, and that leads to one thing, leads to another thing, leads to, oh yeah, I had a knee replacement 8 years ago, and I can't do squats anymore. And so that's going to affect the way your pelvis and pelvic floor muscles are moving. So we'll kind of help you try to identify some of those players of your of what's going on with you and help you put those pieces together. And we're also going to explain the pelvic floor muscles, kind of like we did today. So we've got these models in our office, and we sit down with you and help you understand exactly what muscles we're looking at when we do our assessment before we do it, and what we're looking for. That way you know what's going on in your body. We always value you being empowered to know and ask questions and just realize what your exam is consisting of. Second visit, we're going to do an exam, usually, because it takes a while to get that first visit in. Second visit, we're doing the exam and telling you what we're finding, and then we're going to tell you what you need, right? So we're going to develop a plan based on what we find during your exam. Pelvic floor muscle strengthening or down training. If you tend to have tension in those muscles, we may use biofeedback, we may not. We may need to be cueing you on how to appropriately do a Kegel, if you've heard that phrase, or pelvic floor contraction, or how to appropriately relax those muscles. So we're going to go down one of two pathways there and be helping you along each step of the way. Usually at treatment sessions, you may be getting undressed and we may be working on your pelvic floor muscles, or you may not be getting undressed and we might be working on your back, just depending on what we find during the exam. More on the treatment session. So abdominal muscle strengthening, like we mentioned before, abdominals and lower back and diaphragm are huge. So we'll probably be doing a lot of breathing exercises as well. Behavioral modifications, touching base on what did you try this week? How's everything going? How's your exercise going? Diet going? Hydration, all of that stuff. And then patient education as well. All right, so that kind of wraps up what we have for you guys. Any questions for us? Please post it in the chat.
Okay, and I'm going to unmute you guys. So I'm going to stop sharing so y'all can see.